Hi, everyone. Welcome to the Patients Have Power podcast. We're here with Aaron.
Hello.
Wow, this has been a whirlwind to get to this podcast.
Yeah, kind of a jam-packed end of the week last week.
Yeah, so this podcast was originally just going to be on Right to Try. We did the Twitter chat last week. We are excited to talk about that, but we decided that we wanted to take some time to actually bring in the conversation now happening around pre-existing conditions.
So let's talk a little bit about how we got here. And I think it was a pretty calm Friday afternoon when we saw the news break.
I cannot believe that this conversation is back in the news. I'm actually in shock, and we're going to walk you through what this means. I don't remember how long ago it was, but you might recall people posting, "I am a pre-existing condition" everywhere on social media.
Right.
There was a really, really great movement around it. And all of a sudden, the conversation has opened back up. And so what's going on here? Why are we talking pre-existing conditions again?
So on Friday afternoon, the Trump administration moved to sue the federal government along with 20 state governors. Is that right?
So what happened was there were actually 20 conservative states led
That's
by
right.
Texas who are arguing that the ACA is unconstitutional in its entirety because one piece of the ACA was
The individual mandate.
the individual mandate was
the
revoked.
tax or the penalty that you would get charged for not having insurance got repealed in November or so.
Or in December.
December.
In the big tax reform bill that came out back in 2017.
Yep.
A year ago. Well, not a year ago.
Seems like a lifetime ago.
Yeah.
So anyway, it's back in the news because there is this argument now working through the courts where they are trying to argue that the entire thing is now unconstitutional. And
and the problem is that the administration is refusing to defend the ACA, which is actually really unheard of because it's pretty standard for current administration to support what laws are already in place. And so the Justice Department is not stepping in to defend these laws.
Yeah, so it's not looking great, but the law of the land still remains the ACA, so all pre-existing conditions are still covered and protected.
Yeah, so let's actually say that with the ACA, for those of you who don't know, the Affordable Care Act, there are some regulations and protections in place for people with pre-existing conditions. So what does this mean? This means that insurance cannot refuse to provide care or insurance to somebody living with a pre-existing condition. It also means that they can't hike up costs and premiums because somebody is living with a pre-existing condition.
So for instance, you have Crohn's.
I have Crohn's, I've got psoriatic arthritis, I've got psoriasis.
It's a whole thing.
It's a whole thing. There's a list. There's more, but we'll just leave it at that for now.
And so you cannot legally be charged any extra than, say, me.
Yeah, thank God, because, I didn't do anything to deserve this. These diseases happened upon me. There is nothing that I have done to bring this upon myself.
So some statistics here, 88.9% of respondents in a recent survey of IBD patients said it's already difficult to afford coverage. 55.3 were turned down by an insurance company, and 51.8 were charged a higher rate because of their pre-existing condition.
So this was prior to the ACA being put into place, and that is just...
It's appalling.
Appalling that these patients who are already living with so much stress and trying to get their treatment under control, they're being denied coverage, which means their disease is just progressing and getting worse. And you know what ends up happening then? Patients end up in the ER.
Right.
And then they go bankrupt because they can't afford to pay the ER bills, and they don't have insurance because insurance won't cover it. Somebody tell me how that makes sense. I'm just mind blown by all of this.
I think there's a common argument from more fiscally conservative sides that argue that healthcare should not be granted universally because of the individual costs that all kind of accumulate and get handed off to so-called healthier folk. But the fact of the matter is, we all pay for this stuff one way or another. And if 130 million adults under the age of 65 have pre-existing conditions. So if we're talking about 130 million people with pre-existing conditions who somehow get thrown off of insurance, it's not going to be a case in which or like someone like me who doesn't really have anything happening in his body, theoretically, it's not like I'm getting off scot-free. I'm still paying for this somewhere down the line.
And also, I think what's really important to remember is that, yes, you could be healthy today, but what about in a year from now, or 2 years from now, or 10 years from now? Really, not everybody gets away with being healthy their whole lives. We need to use the healthcare system at some point.
Right.
You cannot avoid it. And so actually, even revoking this individual mandate is kind of bananas to me, but we don't need to get into that right now. We'll just leave it there.
Well, and the wild thing is, so Lilly was kind enough to do some more research beyond what we had both read. And the wild thing was that the trade association, sorry, let me get this completely straight. So the Insurance Trade Association supports pre-existing condition protections. So I'm not entirely sure which cohort of America this is meant to protect.
Well, it's funny because we are always giving insurance companies a hard time, and in this time, they're really in the right here. In polls, in really reputable polls, I think it's Kaiser tracking poll back in June 2017, majority, Republicans and Democrats, support protections for people with pre-existing conditions. You know what's even interesting is that back when Trump was actually first elected in a 60 Minutes interview, he said that this was one piece of the ACA that he actually liked, the protections that were in place for people with pre-existing conditions. But now, I'm not so sure what happened there.
So it's going through the courts right now. I think one thing that everyone needs to do is get activated. If you know someone, and I promise you know someone with a pre-existing condition, I promise you will know someone who has to go through the healthcare system. If this bothers you at any level, and I think it really ought to, if you know people in general, if you know anyone.
Well, yeah, I mean, just an FYI, it's not just people with serious chronic conditions that this fits. It's
what are some pre-existing conditions that are on the list?
If you're pregnant. So if you are going to bring life into this world, pre-existing condition.
Acne was a pre-existing condition.
So, those little pubescent children causing problems, wreaking havoc in society.
I mean, it's hard enough to have acne and go to the middle school dance.
Yeah.
Now you might get thrown off insurance when you're older.
No coverage. So no acne creams.
Again, if this bothers you, and it really should, it will impact you or someone you know, call your representatives, call your congressmen, call your senators. Jam up the phone lines and make sure that your voice is heard.
Texts. These are all things that you can do, and we'll try to list some resources along with this podcast when we do the write-ups, so that you have some quick and easy links that you can go to and contact your representative.
Oh, and there's one guy that I've been following on Twitter that's been really, really helpful. He calls himself Medicare Matt. He's a lawyer who has a chronic illness, and now he's an activist and also still a lawyer activist who fights on behalf of patients. So if you want to shoot him a follow, it's at MattBC, Matt Bob Carroll, I guess BC. And he's been a fantastic follow, really great information. Yeah. And selfishly, the way I kind of frame this in my mind is, here at Clara, we have this great patient advocacy program run by Lilly. And if somehow Lilly couldn't afford insurance or couldn't afford care at all.
Or was just denied.
Right, or was denied care. I'm not entirely sure what would happen to my life personally. It would be such an influx of extra work that I don't think any human could be able to take care of it. And then, all of a sudden Claire's gone. And
the podcast, the ratings go way down.
So again, someone with a pre-existing condition, you will know someone, you might be one. Get involved, make your phone calls, or send your emails, and tweet, make your voice heard.
Social media is really impactful now. We know our president also loves social media, so I think
he's
that
on there.
It's go ahead and tweet away. We will be continuing to talk about this as it evolves. I'm really hoping that this discussion just gets to stop and we get to keep it doesn't become a big issue, but right now we're following it and we'll try to keep you in the loop on it.
And this is one of those cases where there just isn't another side, unlike this next topic.
This next topic, that was a great transition. I appreciated that.
I've been working on that. I think it went pretty well.
Debatable.
Yeah. Well.
Right to try. we have been following this one for a couple months
That's
now,
right.
and we've been talking about doing a podcast on it, but we really didn't feel we were ready, and we didn't want to speak too soon. We wanted to make sure that we had all the facts. We really wanted to also go to the patient community and talk with others and the biotech community and the insurance community, find out what people are thinking about right to try, because it shouldn't just be Aaron and I's opinion that we're bringing here. We want to have everyone's voice at the table, and it's a complex issue.
Yep.
Right to try. So what is it? Right to try allows terminally ill patients to access therapies that are not currently approved or available. So as we've talked about before, treatments have to go through clinical trials, and then they get approved by the FDA, or not approved, but the ones that are approved and on the market are the ones that are available to the general public. And so one would say, well, isn't that what clinical trials are for, right? That
The right to try.
The right to try, you try the clinical trials. The issue is that not everybody will qualify for clinical trials. So they're pretty specific in who they let in, because they want to make sure that the drug is going to be, or the treatment or the therapy is going to be the right fit for the patients who are entering the trial.
Right.
And what's great is that allows for hopefully better outcomes for those patients, but we also know that there are outliers and patients who maybe are presenting differently, and now they're not getting access to these treatments and potentially could die before that treatment is approved. And so there's a couple of different, there's not a couple, there's two different philosophies on this. There are proponents and opponents. I will say, first of all, and I think we didn't mention this, is that right to try was actually recently signed into law.
That's right.
Just a couple weeks ago. And so this is fresh off the press, and at this point, there's not any turning back in the near future, but it's important to us that we talk about what we liked about it, what we didn't like about it, and what patients think about it, and what are the steps moving forward.
Right. So on the proponent side, a couple of major points. Essentially, the argument stems from not wanting to have so many regulations in place between a very sick patient down to perhaps her last option and potential treatment. So, like Lily was saying, clinical trials are actually quite exclusionary and quite restrictive in who they allow into the trials at any given phase. So most patients are excluded from clinical trials because of these criteria. And there was a study on asthma trials that found that on average, only 6% of real-world asthma patients were considered, quote, healthy enough to join any one of these clinical trials. So again, pretty restrictive access there. Of course, there is something called compassionate use of drugs. So that's a pathway through which patients who are very sick can access new therapies without going into clinical trials.
Right. And that process involves filing some paperwork with your physician, and that process was actually recently streamlined because people were saying it was too cumbersome. It's actually recently been streamlined, and that goes to the FDA. And the FDA will then say yay or nay. 99% of all requests that went through to the FDA were approved in the past year. And so that is a way that exists, an avenue to access these treatments. The catch here is that the patient and physician, once it's approved by the FDA, needs to go to the sponsor company or the biotech or pharma company who makes the drug. And they also need to approve that the patient can have access to this drug. Another catch. The pharma company is not responsible for paying for this medicine. And so it could put the patient could be financially liable for this.
So the proponent argument here is that compassionate use, even in its current form, is too cumbersome and complicated for anyone to really reasonably navigate.
And that people should have the fundamental right to make that decision without the government getting involved, to have the right to try.
Right. So again, the government regulation slows down promising treatments. This would be the argument. Gets in the way with oversight that's unnecessary. Clinical trials are too restrictive, and compassionate use is too cumbersome to get through. So those are pretty much the big points on the proponents.
Yeah. Yep, that was a good overview.
Yeah, thanks.
So on the opponent side, there's a couple of different arguments happening here too. One of them is that it's providing false hope to these patients, and it's saying, because here's the issue. it's allowing access to drugs that have made it through a phase 1 study. We know there are some preclinical studies, and then there's phase 1, 2, 3 before you get to approval. And so this is drugs that have gone through phase 1. Unfortunately, only about 13 to 14% of drugs that go through phase 1 actually make it all the way to the approval phase. And so the likelihood that this treatment is really going to be effective is a 13 to 14% chance. And the problem is that the patient is potentially financially responsible for this, because yes, you've cut out the FDA in the equation, but the patient still has to get clearance from the sponsor company. And the sponsor company can say yay or nay, but they can say yay and say, yeah, but we can't afford to pay for it. And I'm not sitting here saying that pharma and biotech companies should pay for every patient who tries to access drugs via compassionate use or right to try. I think it's complicated. We work with a lot of companies, some who are very small biotech companies who are coming up with these innovative therapies, and they simply don't have the funds to be giving away free drugs outside of clinical trials. And so that's a piece of this that concerns me. And I also get concerned that patients and families are going to go bankrupt because they're going to exercise their right to try. And then the patient's going to try this medicine with a very low likelihood of working. And they had now spent hundreds of thousands of dollars on it and have left their family in debt.
Yeah, that's one of my big hangups here as well.
Yeah.
It seems like another instance of this healthcare system in our country offloading some more of the responsibility onto the patient and onto the patient families. I don't think it's any crazy controversial thing to say that our country gives a huge portion of the burden to those who got sick and those families who are taking care of those who got sick. And this just seems to be one more case in which we're not looking at the pathways that exist within the system. So the FDA approval through compassionate use and then going to the pharmaceuticals, we're not looking at those existing pathways and saying, well, how can we improve things or streamline things or what have you? Instead, we're saying, well, let's just get the government the hell out of the way and then let everyone have the free choice, which sounds great on its face, and right to try sounds great on its face, but the underpinnings are a little concerning to me.
Yes, I think so. And it's one of those bills, and I've been kind of calling it this vanity bipartisan. It sounds wonderful, right? All sides are getting involved and people are proponents of it. But when you really pull back the layers, there are some concerning pieces to this. You can kind of tell where Aaron and I, where we stand. We're not being particularly unbiased.
Well, I mean, if
here.
you went to the Twitter chat, you know how we
you know how we
generally
feel. But we have taken a lot of time to look at both sides because we weren't sure where we stood when we first heard about this a few months ago. And so the other thing that I will say is there is some concern about what happens when a patient gets access to a drug via right to try. If there was to be an adverse event, if the patient was to die, that could affect the drug and the outcomes for the patients who are currently in the clinical trial. It creates bad press, and potentially that could prevent that drug from getting out to the general public and saving a lot of other patients later on. And so that's just something else to consider in all of this.
So the opponent points, I guess, then would be,
yes,
it can foster false hope. Insurance and pharma are not required to cover any of the costs, therefore the financial burdens placed on the patient themselves. Compassionate use already approves 99% of requests, and again, limiting that potential good outcome of a drug that might already be in trial if there were to be some horrific adverse event that got hugely publicized.
Again, solid overview. So I want to take a moment to, now that you've heard Aaron and I's strong opinions. I would like to take a moment to share some quotes from the Twitter chat that we actually conducted last week, and where we had a wide array of people from across healthcare. We had a lot of advocates. We had some people from biotech. We had nurses. So we really saw a lot of different perspectives, and a couple of people who were more on the proponent side. I don't want to say they were totally, some people who were in this chat were a little middle of the road and had different comments, so I don't want to put them in a bucket. But Brooke Abbott, she goes under the name Crazy Creole Mommy. I adore her, and I actually really look to her for a lot of policy decisions. She said, I like the bill. I think there is a lot of vagueness in the text, but I think it could lead to better control of over-treatment by doctor and patient. I also think it could open the door to bigger research budgets and more awareness for trials. That was Brooke.
Yeah.
Kelby. When you're on your, Kelby Peachy, she goes by Peachy Pains on Twitter. We'll link to all this as well. When you are on your deathbed, what wouldn't you do? Especially if the FDA says that a drug is safe enough to be used in trials on humans, then it's safe enough for a dying person to make their own choice about whether or not they would like to try it. And finally, I want to share one from Frank on the proponent side, who he actually was featured on NBC Nightly News talking about Right to Try. He's been really, really active in this. Frank is one of our Breakthrough Crew ambassadors, and he's been a phenomenal advocate for the cause. I am for Right to Try. I am a patient that is terminally ill. I was declined for 5 clinical trials, and compassionate use wasn't so compassionate for me. I was denied 2 times. So this is somebody who has been failed by the system and is actively supporting Right to Try. A couple of the opponent sides, do you want to share some of those?
Sure. Yeah. So Kim Hartman, who goes by Automatic RN.
Autonomic RN.
Sorry, Autonomic. I don't know. We'll link to all this, obviously. Yeah. So just look at the link. I don't know what to tell you. It's on a piece of paper. So Kim, she says, I'm split. I'm not 100% sold on it, but not all against. Having another option for patients and families is nice. However, the risks that go along with it and circumventing the FDA concerns me. Some processes exist for a reason. Mm-hmm. So that's Kim. Heather says, I've been strongly opposed to Right to Try. It uses patients to advance the goal of weakening the FDA. I'm also concerned with a false narrative that the government is keeping cures from patients. Now that Right to Try has passed, it's important for patients to be educated about their options, clinical trials, and a realistic picture of what to expect. It could help some, but there won't be a wave of cures. And one more that I'll share here is Kevin, who actually comes from the world of pharma. Yep. Had a lot of fascinating points to make, but this one really resonated. He says, I continue to be opposed. Right to Try adds no new ability for patients to access experimental treatments. It has created a confusing parallel path, and it only provides sound bites and photo ops. So, and then he goes on to say, the vast majority of physicians are not equipped to know enough about the existence and data around experimental compounds, let alone to manage the unknown benefit and risk of treating with them. So simple question, what dose will they prescribe? In reality, the decision still remains with the sponsor company. They know more about the experimental compound than anyone. They carry the risk despite this legislation. FDA is not the bottleneck.
Interesting. So as you can see, we had a really robust discussion, and we'll be sharing that. We also pulled together some resources, sharing the proponent side and the opponent side, and I'm really interested to see how this evolves over the next couple of years, the usage of Right to Try versus compassionate use. I will say that whatever it may be, I hope to see reform across one or both of them, because right now I don't think the system is as efficient as it could be. But I appreciate Brooke's sentiment that, she hopes it opens some doors to have additional conversations around it.
I totally agree with that. And the good news is midterm elections are coming up in November.
Yes.
Big election year for all of America.
And, I will just say in some of the headlines and doing research for the podcast this morning, all of the headlines are now saying that healthcare is going to be the issue that defines the midterm elections.
Yeah, I mean, it makes total sense, right? Again, it impacts everyone. It impacts you, impacts me and Lily and everyone. And I can't stress to you how much my life would get severely impacted if Lily were too sick to work. It would be
So just do this for Aaron.
Yeah,
That's
just
all
do
we
this
care
for me.
about. It's not even
But-
about me. It's about Aaron's work-life balance.
The good news is that this is now on the ballot, and there are no shortage of resources. So we'll link to all of these as much as we can. But I think there's a clear challenge to the patient community, to the advocate community, to anyone who works in healthcare or biotech or health tech like we do. Get involved, right? Get involved. Find those candidates who are speaking the language that you want to hear and back them. Run for office yourself if you're able. If you're not, maybe, if you have the energy for it, phone bank for one of these candidates that you really believe in. Get involved in online social media. Make your voice heard. Make your phone calls, fax, show up, and get your voice into the discussion, because that's the only way that these folks are going to listen to you. So that's kind of what I hope to see in 2018. And I think it's going to be a really cool thing if we can activate all this energy in the patient community.
And we're going to help you get there. So stay tuned. Keep following us on Patients Have Power. We're going to keep talking about it. We're going to keep educating and bringing this information to the forefront, because this is the foundation. Policy sets the foundation for everything in healthcare and how it impacts our day-to-day lives. So thank you all so much for joining us and chatting with us about these issues. Definitely feel free to leave us a comment, let us know what you think, and tell us what other topics you want to hear about. Thanks, everyone.
Thanks, guys.